Hi guys, welcome back. We shall now be talking about pulmonary thromboembolism, which owes its origin to venous thromboembolism or deep vein thrombosis, which is the leading risk factor contributing to pulmonary embolism. Well, the first question that I would like you to remember in this topic said that what is the leading cause of preventable death? The language was very surprising. He said, what condition or which medical condition can you prevent death in hospitalized patients? Now, I had varied people giving different answers to this question, but do remember that there's a huge spectrum across which patients are admitted, ranging from pneumonia to elective surgery to septic shock to acute kidney injury. So it was a difficult choice to make for most of the students. But then Harrison has mentioned this statement, which they asked in the exam, as the first line of pulmonary thromboembolism, that this is leading preventable cause of death in hospitalized patients is pulmonary thromboembolism. Now, how can you prevent that? Well, you can prevent it by identifying venous thromboembolism, starting the patient on heparin or low molecular weight heparin, fondaparinux, or better, I would put it like this, because venous thromboembolism occurs after prolonged immobilization. So, in all post-operative patients, you can put up pneumatic compression stockings, which are powered by an air pump, and they will compress the leg muscles of the patient. So, though this person maybe had a massive GI surgery, we don't expect him to walk, but these pneumatic compression stockings will compress the calf muscles of the patient and prevent the development of stasis of blood in the calf veins and thereby reduce the incidence of pulmonary thromboembolism. Otherwise, all hell will break loose, because if the clot is formed in the legs, this patient is lying in the bed, the clot will embolize towards the heart and can go and block the pulmonary artery or its main bifurcation. You can see in this image a CT angiography, a huge embolus. You can see the contrast in the pulmonary artery, which is bang in the middle. Anteriorly is the ascending aorta. This is the descending aorta, and you can see a huge area or a filling defect which is present. That's because of a saddle embolus which is sitting at the bifurcation of the main pulmonary artery, cutting of blood supply and causing pulmonary oligemia. There's a ventilation perfusion imbalance which will cause deterioration of the patient. So all of this is preventable, and that is why this question is what I have begun this topic with. And now we will talk about etiology of this disease, or the reasons why this disease will develop, so that the treatment part also can be handled more effectively. Well, the leading cause of this is deep vein thrombosis, and deep vein thrombosis itself owes its origin to Virchow's triad. Well, you know about Virchow's triad from very junior classes, so I would like to go beyond the routine things of Virchow's triad of hypercoagulability and stasis developing in a patient. I would like to mention the fact that prolonged immobilization, more than 72 hours, is sufficient to cause formation of clots in the soleal veins of the patient, because in deep vein thrombosis we are talking about calf veins, that is soleal veins. The clot can then extend from the soleal vein upwards to the popliteal vein. It can go up to the femoral vein, even up to the iliac vein, and you can understand as the clot will propagate and go upward, it will become bigger and bigger in size. So if you are having large vein thrombosis, what I mean by large vein thrombosis is iliac vein thrombosis or popliteal vein thrombosis or femoral vein thrombosis, then those clots which are substantially big can break off, or a chunk of it, a size of big piece of it can break off from the original site, and it can travel retrogradely via the inferior vena cava into the right side of the heart and can contribute to a ventilation perfusion imbalance developing in a patient. So apart from immobilization, we are finding a lot of other risk factors also responsible. Like, for example, I mean, not everybody who's lying in the bed will be having clot formation. So they decided to do evaluation of why only some patients are having it. And some of them might even be having a family history positive. So prothrombotic states is what I'm pointing at for development of deep vein thrombosis in a patient. Two autosomal dominant conditions that you should be aware of for solving questions. One is called as factor V Leiden mutation. This is in fact one of the commonest hypercoagulable states, congenital hypercoagulable state that you study. The problem in factor V Leiden mutation is that factor V, it belongs to the extrinsic pathway, it is kept in check by binding to protein C. So in our body, protein C, which is the anti-clotting, and factor V, which is the pro-clotting system, the activity of both of them is balanced by each other. And in factor V Leiden mutation, what happens is that this balance is lost because the factor V binding to protein C is defective. So there is an unopposed activity of factor V. It's not checked by protein C. So unopposed activity would contribute to a coagulant state. There would be a clot formation in this patient. The second autosomal dominant condition is prothrombin gene mutation, due to which the amount of prothrombin in these patients is relatively more, and if the clotting system amount is more, then again a prothrombotic state will develop in a patient. Then he can ask you regarding a condition which is not a autosomal dominant one, but is still asked very frequently, antiphospholipid antibody syndrome. In fact, this has become a hot favorite of our examiners, this topic APAS, antiphospholipid antibody syndrome, in recent few years. I'll explain the reason for that. This could be associated with SLE and sometimes can be present even without SLE. This is an autoimmune disorder in which there are autoantibodies present, and those autoantibodies, what they do is that they activate the intrinsic system of clotting. You will appreciate this better when I mention the name of this antibody, anti-beta 2 glycoprotein. This is the troublemaker here. Now let us see what it does. The anti-beta 2 glycoprotein antibody will activate the intrinsic pathway of clotting. Like, in you and me, whenever there is trauma, first extrinsic pathway is activated, then intrinsic pathway, then common pathway. Here, even without trauma, while the patient is sitting across you, talking to you across the chair, the intrinsic pathway of clotting has been triggered, and therefore there would be a clot formation in this patient, and the clots that develop in the legs of this person can then embolize to the heart and can cause pulmonary embolism. In fact, patients of antiphospholipid antibody syndrome are advised not to go for long distance flights. Like I'll give an example. You see, Delhi to San Francisco or Delhi to America flight could be non-stop flight, could be 18 hours. Now, if a person is sitting in a plane for that longer duration, there could be clot formation in the legs. In fact, in Harrison, he has mentioned something as simple as, he says, prolonged watching of television can contribute to deep vein thrombosis. Might look surprising to you. He says sedentary lifestyle, prolonged watching of television in obese American population has been documented to cause increased incidence of venous thromboembolism. If you have ever traveled by flight, long distance one, you will notice that there are repeated announcements saying move your toes, move your calves, try to stretch out a bit, stretch out your legs, because if you move your calf muscles, then the pressure of the calf muscles will keep the blood flowing. And in people who are having a thrombotic state, if they're flying long distance and person is sitting in the plane for long duration, then the clots can develop in the legs. And on deboarding, while the person will walk to immigration counter, there's a possibility that the clot in the legs could embolize and could go into the heart. There has been a question given like this that I'll discuss with you subsequently, where a person has taken a long distance flight. The importance of long distance flight is immobilization again. So whether it is immobilization post-operative or immobilization after long distance flight, prothrombotic state will always be a disaster for a patient. Another prothrombotic state that I can mention is OCPs. Now, nowadays, the OCPs that are available are having estrogen of less than or equal to 30 microgram, but the older generation OCPs were having high amount of estrogen, so they used to result in clot formation. Then if you do hormonal replacement therapy in a postmenopausal woman, you will be mainly giving estrogen. And estrogen again is prothrombotic. So if a person is having all these risk factors that I'm mentioning before you, then the chances of deep vein thrombosis and large vein thrombosis are substantially increased. Cancer is a hypercoagulable state. So all cancer surgeries can end up in a disaster, because though the cancer has been removed successfully, because cancer is a hypercoagulable state, there would be clot formation in the body of this patient that can embolize from the leg towards the heart. So whether he says cancer surgery, gynec surgery, or even if he talks about, if I talk about orthopedic implant surgery, you see in orthopedic implant surgery like total hip replacement, total knee replacement, there is a lot of hammering, chiseling, drilling going on. So due to the vibrations which are produced by the drill machine, there is a possibility, though it's a little rare, but still there is a possibility that the clot that will develop in the femoral vein or maybe develop in the popliteal vein with total knee replacement, that clot will develop due to the trauma caused by the vibrations to the vein. Obviously, it's not a deliberate trauma, it's accidental trauma. Once the clot is formed, it will keep on growing. By second or third day post-operatively, the clot could become so big that it could embolize from the veins, go towards the heart of the patient and cause a massive pulmonary embolism in a patient. So we grade it as massive or submassive, or sometimes you could be having a low risk pulmonary embolism also, which is multiple small clots. But then massive pulmonary embolism will be having higher chances of death in a person, because it will block the pulmonary circulation and cause a ventilation perfusion imbalance in a patient. We will now look at the physiology behind the development of the disease. And nowadays, because they are asking integrated questions where two choices could be from medicine, one from pharmacology and one from physiology. So we will look at the physiological basis of this disease as well. You need to remember that alveolar arterial gradient is increased in this condition. Let us understand why. Capital A here implies partial pressure of oxygen in the alveoli. Air can go in the alveoli of this patient because airways are fine. But the blood supply to the lungs is substantially reduced by a clot. So the partial pressure of oxygen in the small blood vessels which are surrounding the alveoli will be compromised. Why? Because this component why it is reducing is because there is no blood reaching the alveoli. So if the small a mathematically will become less, the gradient will increase. The normal alveolar arterial gradient for you and me is 5 to 15 millimeters of mercury. It means that across this gradient of 5 to 15, oxygen diffuses from our alveoli into the blood vessels. If no blood will go in the blood vessels, then the diffusion obviously, it's a wastage, no? It's a wastage in a sense that oxygen is going all the way, but it is not doing its purpose of forming oxyhemoglobin in the body. So we say it as intrapulmonary shunting. That means that there is ventilation which is going waste in the patient. Therefore, in physiology, he will also say increase in dead space ventilation. Normally, every breath we take 500 ml, 150 ml is dead space, but in this case, the dead space is increased. The physiological dead space is enhanced secondary to wastage of gas because the blood supply to the lungs has been compromised. The development of hypoxia in this patient will also cause pulmonary vessels to constrict. The pulmonary vessel pressure will therefore, or the resistance will tend to increase. Do remember the fact that pulmonary artery is the only artery carrying carbon dioxide, otherwise arteries carry oxygen. Cerebral arteries or all arteries in the body dilate in response to hypoxia, but pulmonary vessels do not dilate. They constrict in response to hypoxia. So MCQ might say increase in peripheral or pulmonary vessel resistance. This hypoxia stimulus in this person will also cause him to breathe faster, that is alveolar hyperventilation. It is not that PO2 will stabilize because of all of this. The body is trying to breathe faster, but after all, there is no improvement. Why? Because the pulmonary artery main trunk is blocked by a huge clot. So even if you send in all the oxygen, it's a waste actually happening here. So you can see the arrow is going up for everything: the gradient, the dead space ventilation, pulmonary vessel constriction or resistance, alveolar hyperventilation, the respiratory rate. He might say what is reduced in the patient. So you will answer lung compliance is reduced in patients of pulmonary thromboembolism. And in these patients, now let us see what's actually going to happen to the patient. It looks okay to read all these parameters, but what's the basic fundamental problem is what you need to understand. And this can be understood from this simple diagram. I've shown here the pulmonary artery. It's the bifurcation and then the aorta. My patient unfortunately is having a huge thrombus in one of the pulmonary artery branches. It is causing a physical obstruction like this. This will cause increase of pulmonary artery pressure here because blood cannot go in this blood vessel. The patient will straight away be having pulmonary oligemia because blood is going only in one pulmonary circulation, not in the other one. The increased pressure will soon cause dilatation of the pulmonary artery. So I have now modified the diagram to not only show increased pressure, but pulmonary artery hypertension substantial enough to cause pulmonary vessel to become dilated proximal to the obstruction. The right ventricle will try its best to push blood against this physical resistance that is increased, but will fail very soon. Therefore, in the same patient, you will now notice a development of RVF. Once right ventricle will fail, the JVP of this person will become elevated and Kussmaul sign might be written in the question. Normally, when we take a deep breath, our JVP falls. But in this case, because the right ventricle is failing and is not having any space, when the person will take a deep breath, the blood cannot go into the right ventricle. So Kussmaul sign will always be written in the clinical question based on this topic. There would be a lot of congestion in the back circuit, including in the right atria. And after a few minutes of the clot landing here, the pressure will be substantially so high that it will result in a septal deviation. That's one of the key features of this patient, that the interventricular septum is shifted in this patient because this ventricle is volume overloaded, it is dilated, and this septal deviation will contribute to decrease in the cavity size of the left ventricle. Therefore, less blood will come in the left ventricle. If less blood will come in, less will go out, and therefore the blood pressure of this person will begin to fall. You can appreciate the strange phenomenon occurring here, that problem is on right side of the heart and BP is falling on the left hand side. This presentation that I mentioned before you is technically called as acute cor pulmonale. In fact, this is a question: what is the cause of acute cor pulmonale? Your answer would be the topic we are discussing, that is pulmonary thromboembolism is the leading cause of acute cor pulmonale. If the question is asked as what is the cause of plain cor pulmonale, then the leading cause is COPD. that is emphysema, chronic bronchitis. But acute cor pulmonale is to be answered as pulmonary thromboembolism. Let us practice all the events that have happened here. The first thing that happened was pulmonary oligemia, that explains the respiratory distress. The earliest symptom of these patients is unexplained breathlessness, like a post-operative patient, day 2, day 3, there is suddenly a breathlessness in the patient and maybe a developed a chest pain also. You might think it is MI, but he's not having a myocardial infarction. He's rather having a acute right ventricular decompensation. Then is increase in the pressure in the pulmonary artery, which will result in sudden onset RVF. Because pulmonary artery hypertension is a sudden onset, so right ventricle will fail suddenly. This will result in elevated JVP, small sign developing in a patient. In fact, this dilated right ventricle with a septal shift or septal deviation can even be seen on echocardiography. There was a question in radiology on this topic called as McConnell sign. Meaning of the word McConnell sign can be interpreted from the diagram that I just showed to you, that the right ventricle is dilated and it is not functioning properly. So McConnell sign has two findings, where the first one I've shown before you is dilated right ventricle, which is written in MCQs as hypokinesia of the right ventricle. For the next one, I'm not providing an explanation, but that's the second finding that is seen in this patient, hyperkinetic apex of the right ventricle. So get the words right. There is a hypokinesia of the entire wall of the right. That's related to fluid mechanics and fluid dynamics, that the right ventricle hole is grossly dilated, but there is an increased activity found in the apex of the right ventricle, probably because the right ventricle is doing a last ditch effort to pump blood into the pulmonary circulation. So McConnell sign is an echocardiography finding that can be seen here. So we can link the pathophysiology part with radiology. Once the right ventricle decompensates, there is also a septal deviation. This decreases the cavity size of the left ventricle. Therefore, left ventricle will be receiving less blood. Normal endostolic volume is 130 ml. If less comes in, less goes out. The BP will begin to fall in the patient. This presentation is called as acute cor pulmonale or right ventricular strain developing in this patient. Because in these patients, the right ventricle is compromised, there's a possibility that you might think that person is having a right ventricular myocardial infarction. In fact, in these patients, sometimes troponin I can be elevated. Why? Because when there is a gross dilatation of the right ventricle, it might compress the right coronary arteries. So I'm just mentioning as a point number 6, a right coronary artery can be compromised in the patient, which can result in not a full-blown but micro infarctions, because the smaller branches of the right ventricle will be compressed due to dilatation. You see, the vessels are on the outer surface of the heart. When the right ventricle is suddenly dilated, those small blood vessels can be compressed and there could be micro infarctions documented, which can cause an elevated troponin I in this patient. So right ventricular MI can be a misdiagnosis of this condition or could coexist with this particular condition. Even if you treat the MI component, he may or may not fully improve, because you have treated the MI component, but maybe you have not been able to handle the pulmonary embolism component of this patient, because he will require a long-term anticoagulation. The bottom line is that pulmonary thromboembolism can actually coexist with other illnesses or can present by itself suddenly. The textbook calls pulmonary thromboembolism as a great masquerader. Coming to the clinical features of this disease, it is referred to as a great masquerader. Why? Because the clinical features might look like that of myocardial infarction. You see, you are having chest pain in this patient of pulmonary embolism. Why chest pain? Because the pulmonary artery branches are getting blocked, so they could be pleural infarction. So the actual cause of chest pain in this patient is not coronary ischemia, but it is primarily pleural infarction causing a pleuritic chest pain which worsens with inspiration. Breathlessness is explained by pulmonary oligemia and less blood going to the lungs of the patient. Now, you will appreciate this better if I describe the description in the form of a question. This is a 75-year-old man. He has undergone a total hip replacement, a bilateral THR in my hospital about 3 days back. This is day 3 of illness. Late evening, when I was finishing my round and I was planning to go back home, the nurse of mine told me that this 70-year-old man, he was pressing on the emergency bell again and again. And when the nurse went to the bedside, she could not understand anything because the patient was having extreme amount of breathlessness. So she called me. She says that about 10 minutes ago, when she had gone to maybe change the IV fluid bottle of this person or some other reason she had gone to the bedside, the person was fine, and now suddenly within 10 minutes he is deteriorated. So we need to understand what really happened within that 10-minute period that this person is having a sudden onset extreme dyspnea and chest pain. I examined this person. I found his heart rate was suddenly jumping up to 120 per minute. There was blood pressure of only 90/60. He was maintaining his vitals earlier. When I had taken the round in the morning, he was fine. In the afternoon, I found him having lunch. When I was taking a round of opposite side of the ICU, I found that this person was having his lunch sitting up in the hospital bed. So he was okay, and then suddenly is deteriorated, and there's a hemodynamic instability developing in the patient, and the BP will crash very soon also. So I need to be very careful. And the JVP is elevated with a Kussmaul sign. It's not falling. JVP is not falling on inspiration as it normally should. When I auscultated him, I could hear a loud S1, which is obviously a feature of tachycardia. And when I heard a second heart sound, it was wide split second heart sound. Why wide split? Because there's an obstruction to the right ventricle by a clot. So right ventricle will not be able to pump blood into the lungs effectively. So pulmonic valve cannot close on time. Pulmonic valve will close late. This will be a wide split second heart sound. I'll just make you practice this here. First aortic valve closes, then pulmonic valves. The gap between the two is about 30 millisecond. In this condition, the right ventricle cannot effectively empty, so pulmonic valve will close late. So I'm moving the P2 slightly to right, therefore the gap has increased by more than 30 milliseconds. We call it a wide split second heart sound. It can even be wide fixed split second heart sound. So wide fixed split second heart sound is always read by you in ASD and then in massive pulmonary embolism in a patient. When I will change the side of my stethoscope and hear him with the bell, I will be able to hear a third heart sound in this patient. So S1 and S2 will be heard with diaphragm, and S3 is a low pitch heart sound. It will be heard with a bell that is telling me of a failing heart. But when I will auscultate the lungs of the patient, there will be no pulmonary edema, no fine crepitations. Lungs will be clear. That is itself a question, that which finding will not be found in massive pulmonary embolism. Then because there is no pulmonary edema in this condition, I said bilaterally clear lungs or bilaterally clear airfields or lung fields will be auscultated by you. Pulmonary edema is a feature of left ventricle failure, and this person is having right ventricular failure. So bilateral fine crepitations are never ever going to be heard in this condition. This is a pure right ventricular failure occurring in a patient. Because I might get the impression that this chap is having a MI because everything looks like MI. Well, clinically, this could be right ventricular MI. It could be inferior wall MI. What is telling me clinically this is not an inferior wall MI is only one thing: heart rate. If you go to the cardiology section, I've explained that in inferior wall MI we usually have a bradycardia because vagus gets involved. In this profile or this clinical picture that is given to you, only the heart rate is telling you that it is unlikely to be inferior wall MI, but that's again very skeptical information. So I need to be more sure about my diagnosis, and that is why I wrote on the top great masquerader, because it might look like MI and you might actually start treatment like a myocardial infarction, soon realizing that this was a case of pulmonary embolism. Based on the clinical history of this patient, I will be doing a ECG and a chest X-ray and an echo to identify the disease process and its etiology. But because filling up a requisition form, getting the technician to do a ECG and basic investigations will take a couple of minutes, I would like to utilize this time to work out the probability of him having pulmonary embolism. So we now have what is called as Wells criteria, and they are designed to basically utilize this time that the doctor is having to think about the probability of pulmonary embolism in a patient. There are multiple parameters, but I'll try to just use a mnemonic to simplify things for you. You can use this word BDC HIP, so we can identify the patient having probability of pulmonary embolism. B would stand for blood in the sputum, hemoptysis. In my patient, post-operative patient, there was no such blood in the sputum, and that's the common scenario. But the problem is that the pulmonary artery and its branches are getting dilated because of obstruction by one large clot or multiple large clots. So it is unlikely that the main pulmonary artery will pop off, but the smaller branches, due to multiple clots, can actually burst, and therefore they could be blood-tinged sputum. D would stand for deep vein thrombosis signs and symptoms. They have been missed by me because this is day 3 when he presented or he had development of this breathlessness while in the recovery unit of my hospital, post-operative case of total hip replacement. But on the second day, maybe he was having this swelling on his legs, on one of the legs, and which was missed by me. Maybe he complained of the pain in the leg, but that was neglected by the nurse or by myself. So deep vein sign thrombosis signs and symptoms could be present in a patient at this particular junction that will add credibility to the diagnosis. Like I can just say Homan sign. Homan sign is that if you do dorsiflexion of the ankle of the patient, it will cause pain in the calf of the patient. That's one of the simple signs that can be elicited apart from swelling of the leg or the girth of the leg that can be compared with the previous examinations that you have done in the patient. C would stand for cancer or malignancy. I have already explained to you that cancer is a hypercoagulable state. This patient, however, underwent a routine hip replacement surgery, but cancer surgery would have given more credibility, or presence of cancer in this patient would have given more credibility to the diagnosis of pulmonary embolism while the investigations are underway for this patient. Heart rate more than 100, hemodynamically the person is having problems on third day. You see, usually first, second day we might have a low grade fever which might cause a tachycardia in the patient, but it usually settles by the third day. So if a person is having respiratory problems on the third, fourth post-operative day, we always have to think in terms of either atelectasis or we have to think in terms of pulmonary embolism developing in a patient. Then immobilization. That is what has happened in this person. Immobilization for more than 3 days is highly suggestive, or is a factor that is highly suggestive of presence of pulmonary embolism in a patient or history of undergoing a surgery in the previous 4 weeks. So in this patient, both have happened. Surgery has occurred and then immobilization has resulted in this clot formation. P stands for prior such history. Why I'm saying this is because I taught you about some autosomal dominant conditions like factor V Leiden mutation or prothrombin gene mutations, and even antiphospholipid antibody syndrome might be person of SLE who's having a hypercoagulable state, so there could be a recurrence occurring in a patient. So Wells criteria are BDC hip that I've just mentioned before you, and another statement I can mention, though I'm not writing it here, is alternative diagnosis unlikely. When I say alternative diagnosis unlikely, I mean all of these are present in a patient. So if they are positive, that gives credibility to the diagnosis of pulmonary embolism. MCQ wise, remember a score in Wells criteria more than 4 puts the patient at high probability for pulmonary embolism while the investigations are underway for the patient. Once you get that, I want to tell you that it is not always that only large clots would be there. There could be another scenario developing in a patient in the following fashion. Just be patient and hear me out for this one. There is a possibility that there might be not one but multiple small branches getting obliterated in this patient by shower of multiple emboli. Same scenarios, post-operative patient, not one but multiple small emboli entered into the right side and they have gone into the distal circulation and are blocking the small blood vessels in the lungs. Because of this also, the pressure in the pulmonary artery will begin to rise, but it will not be very substantial. There is a possibility that right ventricle might begin to fail even in this case, but I have not shown a very significant right ventricular distension in the patient. I have not shown any interventricular septal deviation, so the LV cavity size has been shown to be normal, and if normal blood will come in the left ventricle, then the BP will be preserved. This diagram aims to tell you that there is a possibility that person might be having a submassive pulmonary embolism. I'm calling it submassive because you can see multiple small clots are present. So in submassive pulmonary embolism, the blood pressure usually tends to remain normal in a patient. Therefore, there is a possibility that in a question, he may not discuss a hemodynamic crashing of the patient, or crashing patient word may not be given. There is a milder presentation. On a comparison basis, massive pulmonary embolism is what you encounter usually less commonly. The incidence of massive, like this description that I gave you was for massive pulmonary embolism. Incidence wise, it is about 5 to 10% of the total cases. On the other hand, submassive pulmonary embolism, the incidence is relatively more common. That would be close to about 65% cases. So on a comparison basis, submassive is more common than massive, and therefore the treatment part for both of these patients will also be different. So we next need to study what will be the workup done. My patient is having a high probability score of more than 4 on Wells criteria. I will be doing a ECG to rule out possibility of MI. The findings of myocardial infarction have been discussed in the cardiology section. So in respiratory section, I want you to remember regarding S1Q3T3. S1Q3T3 means deep S waves will be noted in lead number 1. S1 cut S1 Q3 T3 will mean deep S waves in lead 1, deep Q waves in lead 3, and inverted T waves in lead 3. So 3 points have to be remembered. Deep S in lead 1, deep Q in lead 3, and inverted T waves in lead 3. I will now be performing an X-ray in the patient so that I can see whether there is a bat-wing pulmonary edema. In this case, there would be no pulmonary edema present. Let us look at this screw diagram that I'm drawing before you for the heart. This would be the right side, that is the right atria, right heart border. And on the left hand side, I have shown the left ventricle from where the aorta will be generated. Now in the diagram I've shown right ventricle, which is inferiorly located. This is the pulmonary artery, which will bifurcate into two like this. What will happen in this case will be that a clot which started from the legs will enter in the right ventricle, then will go into the right pulmonary artery. And there's a possibility that when this right pulmonary artery is bifurcating like this, the clot has gone and blocked the descending branch of the right pulmonary artery. The movement that will happen, the blood vessel proximal to it will dilate and may be visible on a chest X-ray. And wherever there is a embolus present, the area distal to it will begin to die. So you would be having a pulmonary infarction manifestation developing in a patient. There would be wedge opacity visible on the chest X-ray of this patient because of the pulmonary infarction that I've represented. So the chest X-ray of this patient would be done. Let us now look at one of the chest X-rays that is shown, and you will notice that in this patient there is a very classical wedge opacity that will be noticed, which will be having a apex at where the clot is, and then there would be the base of the triangle will be on the pleural surface. I will just like to draw this representation so that you can appreciate the impact relatively better. In this case, even the cardiothoracic ratio of the heart is substantially increased, but there's no bat-wing characteristic pulmonary edema present apart from that wedge opacity. This is what I've said. This is the representation of the aorta. This is the pulmonary artery supplying the two lungs. And there's an embolus present here. Therefore, the distal area will begin to die down, and you might be having a wedge-shaped opacity that would be visualized on the chest X-ray. This is a very classical finding. The name of this classical finding is an important MCQ by itself. This would be called as Hampton hump. You can notice the triangular wedge-shaped opacity that will develop with the base on the pleural surface and apex towards the clot. Hampton hump is a wedge opacity that helps you identify pulmonary embolism, and the lungs of the patient would be clear. Do remember, this finding will be seen only in the massive variety, not in the submassive variety, because there are small blood vessels which are getting blocked. The proximal blood vessels, wherever the obstruction is present, can get dilated, so there would be a finding called as Palla sign. Palla sign is, remember with alphabet P, dilatation of RDPA, that is right descending. Why the clot goes to right side? That's more of anatomy. Right pulmonary artery takes off first, so right, and then descending because of gravity. So RDPA is right descending pulmonary artery. This is itself a question because they give options like Palla sign is left ascending, left descending, right ascending, right descending. So it is RDPA, right descending pulmonary artery dilatation, that is responsible. The third finding that you get in these patients is called as Westermarck sign. That simply represents focal oligemia. That is, the word focal is only to signify that only one lung segment in this patient has been compromised. It's not that it's a diffuse manifestation in the patient. So most of the time the clot goes into RDPA, that is right descending pulmonary artery, and contributes to focal oligemia, and this X-ray finding would be noticed mostly on evaluation in massive pulmonary embolism and would not be seen in the submassive variety. So I have today told you that if an old man suddenly deteriorates in the recovery unit of your hospital, is undergone orthopedic surgery, cancer surgery, and prolonged immobilization is documented, and then there is a sudden onset respiratory distress. I mean, everything is happening just like that. 10 minutes ago he was fine. 10 minutes ago maybe the nurse had said that this old man, he requested a her to let him talk to his son, through a video call on a mobile phone in the ICU. Like patients might give you requests, "Sir, I just want to talk to my relative for 2 minutes." So you just allowed, and now he's suddenly deteriorated. So if you have a presentation like this, sudden deterioration, post-operative patient, widespread second heart sound, bilaterally clear lung fields, you have to think in terms of pulmonary embolism. While the investigations are on the way, think about Wells criteria, think about what are the associations that could be present by remembering this mnemonic BDC HIP, and then subsequently, while the investigations are done, you will be in a better position to identify the problems of this patient. So workup of these patients is investigations like ECG, chest X-ray. Biomarkers like troponin I should always be done, and in fact some cases might be even slightly elevated, unlikely to be double triple, but yeah, elevated. Why? Because there is right ventricular infarctions occurring in these patients. Most of the time there's a right ventricular myocard micro infarction developing in a patient. Why? Because there's a sudden dilatation of the heart, sudden failure of the heart, and the coronary arteries are also getting stressed to the brim. The coronary arteries are in the periphery of the heart, so there is a possibility of micro infarctions in the patient. He might write deliberately words like heart fatty acid binding protein or troponin I, BNP, B-type natriuretic peptide. Any of these investigations might be written in the MCQ and may be given to be elevated. Why? Because I said that there is a right ventricular microinfarctions that develop in this patient. However, why this infarction is occurring is primarily because of the sudden dilatation of the heart and increase in oxygen consumption of the heart, and that's why the microinfarction component is coming up. So remember that there is no embolus going into the coronary circulation. It's not the embolus going into coronary circulation. It is rather those fragments of the clots are going in the lung circulation. But the microinfarction is because of the sudden increase of oxygen consumption on the heart, stretching of the heart, stretching of the coronary circulations. The fourth investigation that I would like to do in this patient would be a ultrasound or Doppler of the legs of the patient to identify the clot origin. This would give credibility to diagnosis, because normally when you press on the great veins like the femoral vein, popliteal vein, with the ultrasound probe, the vein lumen gets compressed. But here, when you will press on the vein from outside with the ultrasound probe, there would be non-compressibility because there's a thrombus present here. So ultrasound or Doppler of the legs of the patient will identify non-compressibility of the big veins. That will help you identify deep vein thrombosis of the patient. And the clot has obviously embolized from there into the right lung circulation. If you are not having this facility, or to trouble you in the exam, he might deliberately write MRV, that is magnetic resonance venography. That test is rather, I would say, more expensive, but can again, magnetic resonance venography can identify the veins and identify the clots in the veins of the patient. We will now come to the screening test for this condition. That would be D-dimer assay. D-dimer assay can be quantified nowadays, so we will not only say positive negative, but it would be elevated. Why? Because when the clot is formed, the plasmin will try to break down that clot. So fragments of the clot, D-dimer assay would be elevated. That tells you that there is a clot formation going on in the body. The investigation of choice for this condition is CT angiography. When I was at your age, I used to study ventilation perfusion scan, lung scan for the patient, but nowadays don't answer ventilation perfusion scan. It is CT angiography. Ventilation perfusion scan can be done, but most hospitals nowadays invest into CT angiography, and you are just giving a IV contrast and then doing a CT in the patient. That will mark out the pulmonary artery segment, and CT can be done very fast. Therefore, you can scan the pulmonary artery relatively better. In fact, nowadays they are using this term triple rule out CT. So from MCQ perspective, you should know the meaning of the word triple rule out CT. I mean, what is our objective of doing this? He says that in a person coming to you with severe chest pain, if you're doing a triple rule out CT, your objective of the radiologist is to help you identify 3 common conditions which cause very severe chest pain. One is pulmonary embolism. Second is aortic dissection, which is written as acute aortic syndrome. Aortic dissection is common in hypertensive patients. And third is obviously myocardial infarction, that is acute coronary syndrome. I'll repeat the statement once again. Triple rule out CT is a new technique that is being used by interventional radiologists to help a physician make a diagnosis for these conditions like pulmonary embolism, acute aortic syndrome, and acute coronary syndrome, all three present with severe chest pain. So ventilation perfusion scan where we use radio labeled albumin. I'll just mention the word here, radio labeled albumin, though I mean I don't think so that they'll talk about this outdated investigation. So radio labeled albumin can be used here. That will get stuck in the lung circulation because if there's a clot proximal to that, it will be emitting gamma rays. So we scan the gamma rays which are coming out from a particular segment of the lung, because the albumin which is radio labeled cannot travel forwards because there's a big clot stuck bang in the middle of the artery, pulmonary artery, or its branches. In earlier times, there was also a question that I'll write before you, that is gold standard test for this condition. Now, nowadays, there is no need for this gold standard test, that is pulmonary angiography. One, this is more cumbersome to perform. Second, you need a person who's experienced to read the films, because pulmonary tree is very extensive, no? So somebody to be familiar with the anatomy of the pulmonary tree in the night at late evening, that person may not be available. So by the time you are gonna rely on the experience of a person or get that person on the job, person might die. So therefore, this test has gone out of, I would say, vogue, and it's not recommended to be done nowadays. CT angiography is the best way for identification. Echocardiography will be showing a classical finding called as McConnell sign. The features of McConnell sign, I'll make you practice once again. The right ventricular wall, the entire right ventricular wall or the whole of the right ventricle will be exhibiting hypokinesia, but the apex of the right ventricle, that's due to fluid dynamics, will be exhibiting a hyperkinesia. In fact, the first statement is more important for you to understand dilated, grossly dilated right ventricle. So the functioning of the heart is compromised here. I'll now show an image which has been asked in the exam and is easy to identify for this topic. You can notice here the pulmonary artery. You can notice the ascending aorta, descending aorta, and then you can see a huge embolus stuck back at the bifurcation of pulmonary artery. In fact, this is representing a classical saddle embolus. This saddle embolus that I've represented before you is the usual image that has come, and the deterioration in these patients will also be relatively faster. So once we've identified that there is a problem, we need to now see what will we do for management of these patients, and that has to be fast and effective. For treatment of pulmonary embolism, they are using the following terminologies in MCQs. One is the word primary therapy. Mark my words, they're not primary prevention, primary therapy. For prevention, we can use those I mentioned right in the beginning. No, if a person has undergone surgery, he can't walk, we can use these graded compression stockings. We can use these pneumatic compression stockings. They will press on the legs of the patient after any orthopedic surgery or GI surgery, because person is going to be bedridden for long duration. The pneumatic compression stockings will be powered by air pump and they will compress the leg muscles. It would be just like walking, and therefore the chances of DVT will minimize, and therefore the pulmonary embolism part will also become lesser. But if the person is, or the question is saying what is the primary therapy for the patient, then your main answer would be a pharmacomechanical approach. There are two ways to manage this patient. One is straight away go in for thrombolysis slash there is nowadays a catheter based approach used for the patient. What I mean by pharmacomechanical approach is two things. One, I can give L-tapolase to the patient, that is 100 milligram. In a case of massive pulmonary embolism, I can destroy the big clot in the artery of the patient. The disadvantage of thrombolysis is bleeding. So what we are doing nowadays is that we are introducing a catheter directly in the right ventricle and then into the pulmonary artery. So we are using a catheter directed thrombolysis. This will reduce the dose of L-tapolase that you need to give to the patient, because see, he's an old man already. If he ends up with brain hemorrhage, instead of benefit, you have caused a loss. So we are doing a catheter directed thrombolysis in the patient where the dose of L-tapolase required is only 25 milligrams. So the hemorrhagic complications are relatively lesser. And we are also having now devices which can actually suck out the clot in one piece. We can use thrombolysis, and then once you break the clot, you can suck out the clot in one piece. So the fragments will not get distributed to the smaller part or the distal part of the lung. So primary therapy is all about a pharmacomechanical approach. Mechanical here implies catheter directed thrombolysis and then using a special device to suck out the clot which has now been rather disintegrated by the thrombolysis process. In some questions, however, he will use the term secondary prevention. Now you are all aware of PSM, so secondary would basically mean early diagnosis and treatment. So secondary prevention, if that's the word used in multiple choice question, the answer would be given by you as anticoagulation and use of IVC filter. I will talk about IVC filter and its advantage also, but the first approach that you will use would be anticoagulation. We'll have to use specific drugs like heparin, low molecular weight heparin, or maybe fondaparinux in a patient, so that the clot propagation does not occur. Whatever has happened has occurred, but now we need to go in for anticoagulation in the patient, that is with IVC filter. Now, if he says these words, primary therapy, secondary prevention, great, but lots of time what he will do in questions will be, he may not use these terminologies and he might just give you a clinical scenario of a massive pulmonary embolism, or he might mention regarding submassive pulmonary embolism. Submassive is much more common as compared to the massive variety, and then he'll ask you treatment, ideal treatment of choice for the patient. He's not going to use words like primary therapy and secondary prevention. How do you know it is massive pulmonary embolism? Look at the blood pressure value in the question. If the BP is unrecordable or BP is very low, it is massive variety, whereas in the submassive variety, usually the BP will be normal or slightly lower but never unrecordable. He could also give you echo finding, RV hypokinesia. But on this side, there will be, even if he is mentioned about the right ventricle, he might use milder terms like right ventricular dilatation or increased pressure in the pulmonary artery, but he may not use the word right ventricular hypokinesia. So echocardiography and blood pressure as vitals are important. Why it is important to differentiate is also because in massive pulmonary embolism, when you will be doing ECG, you will be getting S1, Q3, T3. But when it comes to submassive variety, ECG will be having only sinus tachycardia. I repeat my statement, during questions on pulmonary embolism, have a look at this terminology, submassive pulmonary embolism. If he's asking what is the ECG finding a submassive, answer is sinus tachycardia. Similarly, if he says what is the chest x-ray finding of massive pulmonary embolism, you have to give classical names that I explained to you, ranging from Hampton Hump to Palla-Sign. But if he says submassive, small blood vessels are blocked. I'll just show you the diagram. Small blood vessels are getting blocked. You will not be able to visualize these blood vessels on an X-ray. So your answer would be given as normal. So when you attempt questions, you have to be very particular about whether he's asking you massive versus submassive. The clinical features of both can be same. He might describe a patient who's relatively old age. That's to highlight the immobilization component, which will be more in old age, because if a young person will undergo surgery, you can motivate him and his body mass muscles are more, that he can still make an attempt to get out of the bed relatively early. But in old age, because muscles are relatively atrophied, so immobilization incidence will be relatively higher. He could mention the person has undergone a cancer surgery, so malignancy could be present in old age. It's in fact more common in old age. And then he might say that this person underwent surgery and there is a sudden onset respiratory distress developing in a patient with chest pain, and usually it will be 3 or 4 days after the surgery. It could be as late as 4 weeks, but usually will be 3 to 4 days, because that's the time required for the clots to be formed. And then he will say that the X-ray of the patient is showing the findings that I've told, or the ECG is showing the findings that I've told, and he will say what is the best treatment for the patient. So clinical history can be same, but then you as a doctor have to identify massive versus submassive. Best test is CT angiography. Screening test is D-dimer assay. So I will do a D-dimer in both sides, do a CT angiography. Now is the treatment. For massive, the main treatment is thrombolysis. I will be using tissue plasminogen activator 100 mg, or it could be catheter directed approach where I will use only 25 mg. For submassive, don't answer thrombolysis. Why? Listen to this diagram or see this diagram again. If you do thrombolysis in this case, it will break the clots into further small pieces. Those small fragments will disseminate even further. Why I was doing thrombolysis in the previous case was main artery is blocked, so I need to force my way across. I need to create a passage. But now the passage is already there for the main artery. Only small segmental perfusion defects are there. So the basic rule of medical science is first do no harm. If the main passage is blocked, open it. But if major part of the lung is getting perfusion, only some segment is dying, then I would still not try to thrombolize this chap, because this can worsen this patient in a sense that one, thrombolysis has its own side effect of brain hemorrhage, and the clots will get broken into further small pieces and they will disseminate even further, so it can deteriorate the patient. At this point, I usually get queries that, you see, doctor, you are saying that if the main artery will be blocked, when you break that clot, would not that cause small fragments? So I said benefit versus loss. If it's a main pathway that is blocked, I need to open it up somehow. Otherwise, the both lungs would die if there's a sudden embolus. But in this case, only some segments are getting involved. So I don't want to worsen the patient. I will not like to deteriorate this patient further by doing thrombolysis. So what I will do is anticoagulation, so that at least the further worsening of the patient can be prevented, and the thrombolytic system of our body, protein C, protein S, antithrombin 3, will gradually clear off these clots. Anticoagulation is done in both cases. Listen to this very carefully. Anticoagulation with heparin is recommended for both massive and submassive pulmonary embolism. The main fundamental difference is that when will you do thrombolysis, then thrombolysis is done exclusively in massive pulmonary embolism. That is the main crux of this discussion, that if you get a question of a post-operative patient, old man undergoing cancer surgery, and BP is crashing, you have to do thrombolysis. That's the only way to save this chap. But if it is a submassive variety, don't do thrombolysis. You will rather break up the clot into further small pieces. That would be counterproductive. Do only anticoagulation in the patient. So this aspect, this slide, if you're getting this slide, if you're getting a hang of this, you are bang on target to solve those questions of massive versus submassive pulmonary embolism. And use BP as a good guide in most of the questions. BP will deliberately be given in these questions in the end. So you just need to identify these differences that I mentioned, and you would be on your way to identify and manage these patients. Based on this discussion, we will now talk about drugs which are useful for management. So the drug that I will use will be unfractionated heparin, or I can use once a day molecule enoxaparin or fondaparinux. He has not mentioned preference of one over the other. First, he has mentioned unfractionated heparin because of ease of availability. The only disadvantage with unfractionated heparin can be one, development of HIT, that is heparin induced thrombocytopenia. Second is multiple dosages that are required and a regular monitoring of APTT that is to be done. APTT target in patients of pulmonary thromboembolism requiring anticoagulation is about 60 to 80 seconds. Normal value is 30 to 45 seconds. Because the monitoring part is cumbersome, so a lot of physicians prefer using enoxaparin and fondaparinux. It is to be given once a day, has to be given subcutaneously, and no monitoring is required. Advantage of unfractionated heparin is hour-to-hour control is relatively better. That hour-to-hour control is not there with enoxaparin because it's a long-acting molecule. Once you have given, it will act for a long duration. So you will not be able to control the bleeding part if it occurs, because like in heparin we can use an antidote, protamine sulfate, but with enoxaparin, fondaparinux, though the chances of bleeding are lesser, but if it happens, you can't do much for the patient. Heparin induced thrombocytopenia, if it occurs, then we have bivalirudin available. We will first give parenteral anticoagulation for 5 days. Why? Because warfarin takes at least 5 days to show its manifestations or show its effects. We will give a combination of parenteral anticoagulation, that is any of the three above, UFH, enoxaparin, fondaparinux, any of the three can be given with warfarin. But warfarin effects will come after 5 days. So we are bridging the first 5-day period by using these drugs. The target international normalized ratio that we need to obtain with warfarin is about 2.5, that is a range of 2 to 3 times. Again, the problem with warfarin is regular monitoring which is required, and if the INR increases suddenly, we might have to use prothrombin complex concentrates of fresh frozen plasma in case of a CNS bleed in a patient. To bypass this problem, nowadays we are recommending NOAC, that is novel oral anticoagulant. Unlike warfarin, whose effect will occur after 5 days, novel oral anticoagulants, they start their action immediately within hours. So that is one advantage of novel oral anticoagulants, and the chances of bleeding is also relatively lesser with them. There are two molecules which are used. One of them is dabigatran. I have explained to you novel oral anticoagulants while discussing atrial fibrillation, atrial flutter to prevent the clots going to brain and prevent cerebral embolism. I've discussed it even in pulmonary embolism on long-term basis to be given to the patient so that we can prevent any further events in these patients. In fact, cancer patients, some of them might require novel oral anticoagulant warfarin for whole life. But normally we give warfarin for about 6 months and then we can decrease the dose to the lowest possible, or we can put the person on heparin. But the concept is anticoagulation is given in both varieties of pulmonary embolism, massive and submassive. First 5 days parenteral plus warfarin, and after 5 days only warfarin slash novel oral anticoagulant can be used. One of the novel oral anticoagulant that is now mentioned in the book and should be remembered is betrixaben. So dabigatran is the standard one, we anyway know about it. There's a new one given, so I've mentioned about betrixaben also. Why I have mentioned about these drugs is because he has also decided to act drugs that will counteract the toxicity. So novel oral anticoagulant antidotes are also available. Let's study a bit of pharmacology here. Antidote for dabigatran toxicity. The name is idarucizumab. So you need to just get these names right. The second name that I want you to remember is andexanet. So it is dexa, the same of dexamethasone. Andexanet is an antidote for betrixaben toxicity, and dabigatran toxicity is idarucizumab. With aggressive anticoagulation, I will be able to manage these patients better. The duration that I will give it is for 6 months, whereas the parenteral molecules like enoxaparin, fondaparin for first 5 days. I will now speak about IVC filter, which is used in pulmonary embolism. What is the role of IVC filter? Well, the first one is easy to comprehend: recurrent pulmonary embolism. Like I have a patient of nephrotic syndrome or antiphospholipid antibody syndrome, factor V Leiden mutation. He or she has already had multiple episodes. So to prevent the episode from developing again, a IVC filter will be deployed in the patient. Second is bleeding with anticoagulation. I started the patient on unfractionated heparin plus warfarin, and there is a bleeding occurring. Now this is a very tricky situation for any doctor, because if the bleeding is occurring, you will have to neutralize it by giving fresh frozen plasma, prothrombin complex concentrates. Once the bleeding is controlled, you are now faced with another clot in the leg. The clot in the leg is very much there. That embolus that is starting from that clot could again go into the heart of the patient and again into the lungs of the patient. So, I mean, it's an unending cycle. No, one hand you are handling bleeding, you neutralize the bleeding, the clots are there. So it's a very delicate situation for any doctor to manage, and therefore IVC filter will come in handy, because when you have neutralized the bleeding part, you can now deploy the filter bedside in the patient. Like for IVC filter, there is no special I would say hi-fi procedure required. It's a simple, like you put in a center line, a IVC filter can be deployed under obviously a proper visualization with the echocardiography machine. But the advantage of IVC filter would be that the chances of clots going again into lungs would be minimized. Then I've explained to you that nowadays we are deploying a catheter directly in the pulmonary artery and giving thrombolysis, which is reducing the dose of thrombolytic drug that we are using. So it is called as pharmacomechanical. Mechanical because they are using devices that tend to break down the clot. Like they might be using ultrasonic waves that break down the clot, simultaneously give the drug and suck out all the debris. So pharmacomechanical catheter directed treatment is also being done in the patient. There's a trial going on this at the moment, and once the results will come, I think this will should become ideally the treatment of choice for this condition. But before the results are out, we will still answer the conventional thrombolysis or tissue plasminogen activator 100 milligram that we use for management of massive pulmonary embolism in a patient. Then I would like to mention a surgery which is only shown in episodes of Grey's Anatomy or House: pulmonary thromboembolectomy. That is, they will show person of massive pulmonary embolism, crashing BP. The surgeon is doing a thoracotomy, emergency thoracotomy, opens up the chest, identifies pulmonary artery, removes the clot in one piece. Looks easy, but obviously is horribly difficult to identify pulmonary artery in a crashing patient and then remove the clot in one piece is pulmonary thromboembolectomy. So if you watch season 1 or season 2 of Grey's Anatomy, that is where they have shown these dramatic procedures. Then because of the backlash from doctors, they realized that they are not supposed to show such procedures which are very difficult to perform or unlikely to have a success rate, because that will make people think that doctors are not taking proper decisions. So anyway, I'll not get into the controversy related to these serials, but I want to tell you that whatever you see in these television serials, that is just to, make it sound very dramatic, and medical science is much more logical than that. So we don't have any fancy stuff going on. It's same, no, like James Bond is a super spy, but actual spying world is really a totally different world. Similarly, medical field is where you need to keep your cool and keep on evaluating the patients on a dynamic basis and handle the patients accordingly. So knowledge is power, guys. Keep working, keep learning on everyday basis. And thank you for hearing me out on this lecture. I have talked a bit about the pharmacological drugs also. Please revise them very thoroughly, because anti-clotting drugs is something which I find that most students are not able to answer very properly in the exam. Like the antidotes for dabigatran was asked, idarisumab, and a lot of guys drew a blank on that. So do practice it, and with practice, obviously, everything is possible. Thank you so much for listening.